Welcome to Voices for a Healthy Legacy, where we chat about health and wellness with relatable medical professionals. I am your host, Dr. Andrea White, a board-certified family medicine physician. Today's guest is Dr. Tennille Webb Humphreys, a pediatric nephrologist. Welcome to the show, Dr. Humphreys.
Thank you for having me.
You are welcome. Okay, so tell us a little bit about yourself and how you became passionate about pediatrics and then moving on to pediatric nephrology.
Absolutely. So I'm from Tuskegee, Alabama, small city, underserved area, limited health resources there. But as a child, that was not the case. We had a very prominent hospital there. And so I remember in second grade, I was admitted for pneumonia, and my pediatrician, Dr. Molly Walker, had a huge impression on me. And from then on, I decided I wanted to be a pediatrician. And so I entered medical school knowing I want to be a pediatrician. I know a lot of times people don't know if they want to do adult medicine or pediatrics, but she had such a huge impression on me. I knew I just wanted to do pediatrics. So it was just my experience with her at such a young age.
Okay. And so you went to medical school, did all your rotations and everything, and did residency in pediatrics. Where did you do your residency?
Sure. I did my residency in Chicago, Hope Children's Hospital. It's in the suburbs of, it's Oak Lawn, Illinois, but it's the suburbs of Chicago.
Okay. Tell us about which medical school you went to, and then you transitioned on to pediatric residency.
Absolutely. So I initially did a post-baccalaureate program after undergraduate at Tuskegee University, and then I attended Morehouse School of Medicine in Atlanta, and it was a great experience. It was actually during my time at Morehouse that I discovered my love for nephrology as a first-year student doing physiology with the kidney. And it was something that was like super difficult, like, oh my goodness, what is this? But I found myself just gravitating towards it, always wanting to study it. When I did cardiology, I was like, I can kind of, push through it. But nephrology just held my attention, and I just kept wanting to learn more. And so as a fourth year student, I did a rotation in Charlotte, North Carolina, in nephrology. And from that rotation, it was just sealed that that's what I wanted to do. I like continuity of care. And so that was a big thing that also kind of drew me to nephrology.
Okay. And so from my understanding, you did a pediatric residency and then you went on to do a fellowship, correct?
Correct.
And tell us a little bit about that.
So I did my pediatric residency in the suburbs of Chicago, Oak Lawn, Illinois. It was Hope Children's Hospital, a smaller residency, about 13 residents per class. There was one full-time nephrologist there, so not a lot of experience as far as nephrology, but I had kind of sealed the deal in med school that that's what I wanted to do. And so we didn't do a lot of things like transplants and dialysis, but I took that opportunity to do an away elective in Alabama at Children's of Alabama in nephrology because I just wanted to get more exposure. And so I applied to fellowship, numerous fellowships, and I ended up doing my fellowship in Pittsburgh, Children's Hospital of Pittsburgh for nephrology.
Awesome. Now that we know a little bit about you and your passion and what got you into pediatric nephrology, tell us what a pediatric nephrologist does, because a lot of people think of nephrologists with adults, being a kidney doctor for adults, but tell me what that looks like for pediatrics.
Right, because it's pretty different. Because the disease process is different in adults and children. So it's basically a physician who diagnose and manage kidney disorders in children. And it's just a wide array of disorders. So not only just things with your kidney like urinary tract infections, a lot of children or even our babies and neonates have genetic kidney diseases. And so that's one big difference from adults. And so we even do prenatal consults on mothers who have a prenatal diagnosis of a kidney disorder, whether that's cyst or solitary kidneys or no kidneys. And so we manage that. Also, your kidney is responsible for other things like managing your blood pressure because of different hormones from the kidney. And so we manage hypertension as well. And then other things like recurrent urinary tract infections. And also your kidney is responsible for managing like your electrolytes. So when you think about things that you eat, like your salt and your potassium intake. And so it encompasses all of that. So genetic diseases, urinary tract infections, hypertension, and electrolyte abnormalities.
Okay. So you all have play a very, very crucial and critical role in the pediatric community.
Yes, we do.
Okay. All right. So is there a specific area that you focus on more than other areas? Do you have a particular focus?
Right. So I focus on acute kidney injury. And so after my initial pediatric nephrology fellowship in Pittsburgh, I did an additional fellowship in Cincinnati in acute care nephrology, where I did acute kidney injury research as well as focused on acute therapies. And so we hear about the patients on chronic dialysis. Just like adults, we do have children who receive chronic dialysis until they get a transplant.
Mm-hmm.
But more acute therapies are things that if someone comes in ill, whether they're septic, have really high potassium levels and we have to do emergent dialysis, or they're so sick they're in the ICU, they're on blood pressure medicines to keep their blood pressure up. We do something called continuous kidney support therapy. And so my focus is on early diagnosis of patients with acute kidney injury and trying to intervene sooner rather than later. Because we see that acute kidney injury can actually lead to chronic kidney disease. And so trying to focus on how can we diagnose these patients earlier to help prevent some of those long-term outcomes.
Okay. That's awesome. All right. So it seems like you are very, very dedicated to making sure when we find out something that's acute going on with the kidneys and then to prevent it from potentially becoming a chronic issue. Can you tell me a little bit about how that counseling piece kind of takes place? Like once you get the patient stable and talking to the parents and their support system, what are some of the things, and I know each situation is different, but what are some things that you try to really counsel them on to hopefully prevent that from happening again?
Okay. It's so many layers to that question because like you mentioned, it depends on the situation. And so starting with the prenatal counseling that we do, which I really enjoy, and we're actually going to start a monthly prenatal maternal fetal medicine clinic in conjunction with the maternal fetal medicine doctors to meet with the parents who are expecting babies who will have some kind of kidney disease, whether it's a solitary kidney or cyst on their kidneys. And so just starting by explaining to them what the diagnosis is or what to expect, and then to talk to them about their goals of therapy after they give birth. What do they want us to do as far as offer all the interventions that we have? And so making sure that they're involved in that decision and letting them know that they can change their minds at any time. For our sicker patients who may be born with certain genetic diseases that we know will progress to chronic kidney disease and end-stage kidney disease, later needing a kidney transplant, we talk about that. And with the emphasis on their different stages, first we have to get them if they're on the respirator, making sure that, okay, we can get their lungs healthy and we can perform dialysis in really, really tiny babies at our hospital, which is a plus thing that a lot of hospitals can't do. And so we provide a lot of education on how to provide dialysis in these really tiny neonates. And that's like 1 kilo babies, really tiny. And just making sure the families know it's not just what's happening right now, but this is a long-term process with the goal of acute dialysis and then chronic dialysis in the form of peritoneal dialysis or hemodialysis, and then in the form of a kidney transplant. And so just making sure along the way to continue to have those conversations about this is going to be a long-term thing. Even with kidney transplants, we know that one kidney doesn't last forever. And so you would need numerous kidney transplants. Even if you do everything perfect, take all your medications, a kidney just only lasts for so long. And so just making sure they know that this is a chronic disease, and at any moment they have the right to have another discussion and say, hey, we don't want to do this anymore, or we want everything done. And so that's starting with the neonates in maternal fetal medicine. For our patients, we do a lot of dialysis in the cardiac ICU. And so a lot of those babies may have acute kidney injury from their heart surgery and being on like cardiopulmonary bypass. I have a specific acute kidney injury clinic once a week that I follow those patients really closely to make sure they don't develop chronic kidney disease. So checking their blood pressure, checking their urine to make sure they don't have any protein in their urine, and making sure their kidney function is normal. So we're really proactive with seeing those patients, and we follow those patients for at least 2 years. So again, educating those parents, like, they did great, they only needed dialysis for a day or two, but we want to follow them in our clinic for 2 years to make sure that everything remains stable. And that's for any patient that's acutely ill, even in the ICU, that to make sure they have appropriate follow-up.
Gotcha. So that's kind of where that continuity of care comes in that you were talking about, where you get to see them when they're teeny tiny babies up until they become a thriving toddler, to kind of be able to see how they progress during that time.
Exactly.
Right. And our parents and I know it can be scary for them, especially. So are they kind of in tune with what you're saying about do you find that they understand the chronic aspect of it? Like, yes, the child can still do well, but this is something that we still have to pay close attention to, even though it may not manifest in like them in a physical way, like them playing and things like that.
Right. And I think the majority of our parents do, but it's something that we continue to reiterate. In our ICU, we have wonderful, dedicated acute nurse practitioners who see those parents like multiple times a day. And we talk about it consistently. It's something we talk about, reminders, just to catch up with them to say, okay, what are you thinking? Any additional questions? Even in my acute patients, when it's a lot going on, you're in the ICU and these patients your child was healthy last week and all of a sudden they're in the ICU and they're on this continuous dialysis therapy. It's a lot coming at them. And so, I tell them it's like drinking from a fire hydrant. It's just a lot. And so I tell them, you know what, you may forget everything I just said. And if so, we can start from scratch tomorrow and talk about it over and over again. So I think just making sure they're educated and just answering all their questions, telling them to write their questions down. But I think most of them start to get it, that it's a chronic therapy.
Okay. Do you think there is an increase in children with high blood pressure and diabetes? And if so, tell me why you think that is and how that can affect the kidneys. Because many people think about high blood pressure and diabetes in adults, but I feel like we're kind of starting to see an increase in it. And you can tell me a little bit more about that in the pediatric community. So kind of tell us a little bit about that.
That's a great question, because I have a lot of people that ask me like, oh, you have patients on dialysis, or you have patients with high blood pressure. And I'm like, yeah, I treat high blood pressure in tiny babies and our toddlers, our children, adolescent age. So absolutely. And I think I saw one recent study said that over the past 30 years or so, there's a 4-fold increase in the number of patients or pediatric patients with hypertension. So I definitely see a lot of those patients. In the adult world, we think more so about diabetes and things like that, and like watching their cholesterol. For kids with pediatrics, and the parents are like, why am I seeing a kidney doctor and not a cardiologist for hypertension or elevated blood pressure? One of the things we talked about earlier, some of the genetic diseases. So a lot of our patients who have genetic diseases, a component of their genetic disease may be hypertension. And so they're just predisposed to be hypertensive just because of their disease process. These sick babies who have been in the ICU and they have all these umbilical catheters and IV access and things like that, that increases your risk for elevated blood pressure too. So they've been sick since they were babies, and so that can increase your risk. Prematurity, and so we have a lot of premature babies now because we have the capabilities to take care of these babies and to grow them, but that also increases your risk of hypertension. And so all these advances in technology, they're great, but there's some side effects or long-term things that can come with that. Another thing though, but like you mentioned, we do have a lot of patients. We talk a lot about cholesterol and making sure we watch our diets. But a lot of things that I find in my population are the sugary drinks, and no one talks about sugar. And I tell people the sugar is the enemy. Like, it's terrible. And so on our board, we have displays for parents, like Ziploc bags, showing them how much sugar is in this Mountain Dew or in these Cokes. And when I see a lot of patients and they drink like at least a soda, a pop a day, and I'm like, wow, that's, that's new. Like, I don't think we saw that back in the day. Not just soda, but a lot of sugary drinks, a lot of things, even like Gatorades that they advertise, which is great, and it has its place for our patients who are like active and they're in sports, and it's meant to replace your electrolytes, that you're sweating, you're losing salt and potassium. But if you're just every day at home chilling, watching TV, you shouldn't be drinking Gatorade because it has a lot of sugar and a lot of salt and things like that. So I think we see a lot of dietary changes. I think families are working late, and so you grab that fast food or you grab that drink, not always purposefully, but it makes your life easier. But absolutely, it's a lot of high blood pressure from like my overweight patients or just some dietary changes. I don't always start them on blood pressure medicine. Depends on how high their blood pressure is. I may refer them to, we have a weight loss clinic to see if we can make some dietary modifications before we start medicines. But some patients it's too high and I start medicines, and I tell the parent, you know what, I think everything is normal. I checked all their labs. If we start working out and losing weight, I think we can come off of this medication. And I think that kind of motivates them, because no one wants to see their 9-year-old on high blood pressure medicine.
Right. I'm so glad you said that, because many times, not just, I'm sure in family medicine I see it, but I'm sure with you too, by the time they come to you as a specialist, they feel like medication is the only answer. So to hear that you can say, hey, the medicine is here, but let's see if we can do some of these other lifestyle modifications. That's excellent. And do you find that a lot of those modifications require other family members in the home to modify things with them as well? And if that is the case, how is that response?
Right.
I'm really interested to hear this.
That's a great question. I had a teenager, really terrible, like wicked hypertension, was admitted to the special care. And the father was like, you know what? It's my fault because I eat like this and I buy it, and it's only in the house because I buy it. He doesn't have a job. And so our entire household is going to have to make a change. And I was like, wow, I mean, that was just great for him to voluntarily say that. And so I do have some patients and parents who say, you know what, the entire household has to make a change because I buy it, and that's how they get it. And so we do have that. But you know what, I think talking about, honestly, even as a physician, and I've gotten much better at it, but it's like that elephant in the room when you're telling a parent that their blood pressure is because they're not eating healthy, or they're overweight, and the parent is also overweight, and you want to come off like I'm not being judgmental, but let's like make some lifestyle changes. But I have never had a family to be offended, but some don't realize, especially the Gatorade thing is such a big thing. But I have had parents who say, you know what, if I don't buy it, it wouldn't be in the house. And so we're just going to make a lifestyle change, which is great. But it's hard. I have kids. It's hard I can imagine, to deny your child something that they've been used to taking. So I do have, I empathize with them in that area too. But we do have weight management clinics available, which is great. And they've done, my patients who have gone have really enjoyed it. So that's a good thing.
Since we're talking about high blood pressure, or just blood pressure in general, so again, we kind of know the range for adults. Most people are familiar with that, but for pediatrics, for the pediatric community, those numbers are a little bit different. And I know guidelines can change over time depending on different studies and other factors, but what's generally accepted as normal blood pressure range for children, and is it different for girls versus boys?
That's a great question. It's very tricky. And I think when I was in residency, I did a QI project looking at how often are we really looking at blood pressure and an accurate blood pressure in children? Because with adults, you have this set cutoff, right?
Mm-hmm.
With children, you have to really take the effort. And now we have a new electronic medical record system that calculates it for us. But as nephrologists, we look at, it's a chart, and you're right, it's based on your age, it's based on your gender, and it's based on your height. So you have to kind of line all those things up and say, okay, I have a 9-year-old female and she's like 50% for height. And so based on those three things, this is what her blood pressure should be. And I don't know how often people actually check that because it's a lot, right? And there are programs that you can plug and chug and kind of figure it out. But that's really important because if a 9-year-old goes to urgent care and their blood pressure is 118 over 70 and doesn't flag red, and they're like, oh, it's fine. And you may talk to a parent like, oh, they've never had high blood pressure, and you get the records. It's like, actually, that's high. Like, for example, it should have been 108 over something. And so it's tricky with kids because it's based on their age and gender and height. The most recent update did kind of cut off at 13 years old. So from infancy to 13, we have that age, gender, and height where we have to kind of look and based on percentiles. But if you're 13 or older, it should be less than 120 over 80.
Okay. And again, this may not be set in stone, but we know we have our babies and our toddlers. When do we generally, like, let's say if there are no genetic issues and there's nothing, no red flags that parents are aware of or anything like that, when should you generally start checking blood pressure in children?
So when they're seeing their physician, they should get a blood pressure checked at age 3. So going from age 3 on up, they should have at least annual blood pressure measurement. And it's hard for our tiny babies needing special cuffs. So if we have babies with genetic disorders or kidney disorders, trying to get them a cuff is really hard to get the accurate size, to get the accurate blood pressure. But if you're seeing your family medicine doctor or your pediatrician, they should check blood pressure at age 3.
Okay. All right. In your experience as a pediatric nephrologist and seeing different disorders in children, have you noticed that some of them, like if they're not genetic issues that are known, are there certain ones that present differently in children versus adults? I'm not sure if you've ever seen that before.
Right. I think certain different, like you said, they're not genetic disorders. Maybe even hypertension. Maybe with our adults, we catch it much, much later. They're having some swelling or having headaches. I think a lot of my kids, they may have just gone to the pediatrician and they checked the blood pressure and it was elevated. And so we asked that they check 3 blood pressures on 3 separate measurements before they refer to us, unless it's like ridiculously high. And so they can be totally asymptomatic. And that's the one thing to like kind of talk to parents about, like, they may not have any symptoms, or they may have had the pediatrician just happened to check it. And so what we check is an echocardiogram to see how their heart is, and not just to look at the structure of the heart, but we kind of explain to parents that the heart is a muscle. So it's just like lifting weights. And so if you've had long standing high blood pressure, the left side of your heart is going to be thickened. And so we really look at that and tell them, this has been going on for a long time. And so in those cases, we kind of talked earlier, like I may say do dietary modifications, but if I see any end organ damage, I'm going to start blood pressure medicine, and we can still work on those lifestyle modifications and possibly come off. But it can kind of sneak up on you. And the reassurance I tell parents, the good thing with kids, like, that's reversible. If we can get this blood pressure down, that you're not working that muscle so much, this heart can go back to normal size, which is what they like to see. But I'm like, I have to start medicine to get there. And then we can also work on those modifications. So I think that's one thing. You're not seeing the strokes and the lower extremity swelling and things that you may see in adults. It's just that the doctor just happened to check it and it was elevated. I mean, you may have kids that may say they've been having headaches and things like that. But it kind of sneaks up on you.
Okay. All right. And so we know there's a huge demand for having specialists, especially pediatric nephrologists, because it's, I feel like there is just such a huge need for it. And so in your opinion, do you feel like there are enough pediatric nephrologists to serve our pediatric community? And if not, why do you think that's the case?
Right. So there are not. I would like to start by saying it's just not that popular subspecialty that everyone goes into. And I think pediatric subspecialty is hard because a lot of adult subspecialties, you can do an extra 2 years after your training. And so you do your 3 years of pediatrics, and then you have to do 3 years of nephrology or 3 years of emergency medicine or whatever it is. On the adult side, if you want to do adult nephrology, you can do an extra 2 years and you're done. I think another issue is the pay difference. Is a huge thing. So if you're not doing it for the love of nephrology, it's not going to be a big turn on. The other thing, I think a lot of people now are going into specialties that are more, you can do, procedures. So like,
Gotcha.
even if you're in the ER, like you can do procedures in the ER, you can do your shift, you can go home, you're not bound by a pager. Even in the NICU and PICU, you can do a lot of procedures. And so the only procedure we really do are kidney biopsies. And for the reason that there's not a lot of nephrologists, you can be very busy. And so your call schedule can be very demanding. If somebody needs dialysis at 2:00 in the morning, you're coming in to do dialysis at 2:00 in the morning. And your patients, like I said, they're chronic patients. So you're seeing them from babies to dialysis to transplant and things like that. And so there is a shortage. We don't have a lot of fellows per year. Hopefully that will change in the future, but we don't. It's a shortage. In Alabama, we're the only freestanding hospital. We have 7 nephrologists at our hospital, and then we have a nephrologist in private practice, and then maybe one in Mobile. So very limited. And so we see a lot of patients coming from all these areas to come in to see us, and we're the only place that offers dialysis. And so there's not a lot, and hopefully people will get interested. I love it. If you love continuity of care and like to see them from infancy and now they have a kidney transplant or they're doing great, it's a rewarding feeling, and families are so appreciative, especially when they get those kidney transplants. But there's definitely a shortage.
Okay. And you do all of this at Children's Hospital of Alabama, correct?
Children's of Alabama.
Okay. All right. So since you have confirmed that there is a shortage of pediatric nephrologists, tell me what a typical clinic wait, I don't want to say a wait time, but let's say if you have a new patient in your outpatient clinic who wants to get an appointment with you. Tell me as of today, what does that wait look like? Because and let me tell you why I'm asking. I'm asking because I want people to know, but let's say if I want to refer someone as a family physician to a pediatric nephrologist, people are just blown away by the wait time, by the wait time to get in. And I'm sure you all have like a wait list, where, someone cancels, which I'm sure is very rare, but I'll let you comment on that too. But what does a wait time look like, and why do they have that wait time?
Right. And so when I was a fellow in Pittsburgh.
And can you tell us what a fellow is? Because some people may not know what that is.
So a resident is someone who does their general training. So whether that's adult medicine or pediatric medicine. And then a fellowship is if you want to do additional specialized training. And so I did a 3-year fellowship, 3 plus 1.5, in nephrology. And so when I was a pediatric nephrology fellow in Pittsburgh, we had at least 10 pediatric nephrologists, and then we had 6 fellows. And so we had a policy that new patients were seen, I think, within 48 to 72 hours, because you have to account for the weekend, because we had so many physicians. And then when you think about the state of Pennsylvania, there are different hospitals in the state who also do dialysis and see pediatric patients.
Right.
And so that was nothing, right? I was like, okay, you're going to see a new patient within 72 hours. So we come here, we're the only hospital. Now there are 7 of us, which is great. And so we just hired a new one, our old fellow this year. So now we have 7, and we currently have 3 fellows. And so the wait time can vary. And so it can be a month. it can be longer. That's something we're really, really, really working on now and trying to get these patients in. And now that we have a new physician on board, opening up new slots, and now that we have 2 new fellows, just seeing them because they have clinic once a week too. But the wait time is long. It can take up to a month. We're trying to really, really, really decrease that. And everybody doesn't just go in a bucket. And so we have people reviewing the referrals every day. And so we've come across referrals that are sent by the doctor. It's just like, oh no, they need to be seen this week. And so even if that means we're going to overbook a clinic because this patient is more urgent or sicker or their blood pressure is way too high, we will overbook and say this patient really needs to be seen this week. But if it's a standard, recurrent urinary tract infections, we don't think it's emergent.
Right.
It's not going to bump someone whose kidney function is twice normal of what it should be. Like, we need to see them today. And so we're working on the wait time. That's one of the things that's unfortunate. But hopefully we can keep getting that time down now that we've added new positions to the practice. So at least 30 days, I would say, on a good day.
Okay.
So, yeah.
So I know that you kind of touched on it a little bit earlier. I know that nutrition can play a role in kidney health or kidney disease. Can you discuss some things that parents need to be aware of that they're not necessarily thinking about when it comes to what can affect their child's kidneys? What are some things that you would recommend that they do? Like, I know you mentioned the sugary drinks. What about some other things that they can do as well?
Some things I think about, and I don't think parents, they're surprised if there's a history of kidney stones in the family that increases the child's risk for kidney stones. And so we talk about that. And so not only is there a genetic predisposition, but things like drinking not enough water. That's the biggest thing about kidney stones. People always think, oh, I'm going to tell them to stop drinking milk. No, it's not the milk. It's if you don't drink enough water. So making sure they stay hydrated, and salt actually increases your risk for kidney stones. And so that's one of the big things I kind of tell them to look out for if there's a family history. One thing that we take, like whenever you have pain, right, you take ibuprofen. So you're going to take Aleve or Advil or things like that. If you have a history of kidney disease, we tell parents that they cannot take Advil or Motrin or ibuprofen because it can affect their kidney numbers. Some patients actually have allergies to ibuprofen and they don't know it, and so they may come in the hospital with like back pain or things like that. It can actually cause inflammation and swelling in your kidneys, and so that's called an interstitial nephritis, and so swelling in your kidney, and it can cause pain, and that can be due to NSAID, so like all of the Aleve and ibuprofen. So we always educate all of our parents, regardless if they're coming to nephrology. We talk about the ibuprofen use, because I think it's very common to just, pop an Advil. I'm having pain. So if you're having vomiting or diarrhea and you're not drinking well, that's one thing we really urge them to stay away from. So I think hydration is key, making sure they drink enough, and then staying away from the salt, especially with kidney stones, because everyone thinks milk. And it's not the dairy, it's the salt and the limited fluid intake.
Gotcha. So, and I know you all have a lot of different resources that you can use within your clinic as far as nutrition is concerned. Do you ever personally talk to them about like labels? Because there are so many things that have like salt. So do you tell them give them examples of like maybe canned foods or different other foods to kind of really pay attention to or kind of minimize because of the salt?
So many layers to that question. I love that question for multiple reasons. So I'm going to try and piece it together. The first thing is, yes. So we have all types of handouts on things like low salt, certain kidney diseases, like our patients who have nephrotic syndrome, which is a disease where your body is losing protein that you need, and it causes swelling. So anytime you have a lot of salt, it's going to worsen that swelling. And so we give them packets on things about salt and things that have high salt. Our patients who have to watch their potassium and phosphorus, we have all of these packets. But one thing about our practice or being at Children's, we're super spoiled. And so we have 2 dedicated nutritionists or dietitians who come to clinic and talk to these patients. And so if I have a patient who's overweight, I have the dietitian come and they meet with the family. They stay in contact with the family. They are amazing. And so kind of spoiled to have that. And they do all of that education as well as give them packets and check in with them. Even our babies who may need special formulas, they make sure they get the special formula that they need because it needs to be low in potassium. So we have a lot of handouts, and then we have the dietitians to reinforce that education and follow up with them. And so they know when they're coming back to clinic, they meet me in clinic to evaluate them at the same time to see how things are going. You mentioned the canned foods, and thinking about our population, especially in Alabama, and our patients who are on dialysis and who may need assistance with food. So whether that's getting government assistance for purchasing foods, one thing we don't think about, even if you're not getting government assistance, I have had like social workers talk to the patients about they can't understand why the family can't just eat this or that. And I'm like, they're on dialysis. They can't eat canned string beans. They can't eat all this canned food. So to just empathize with those families, it's expensive. They need fresh vegetables. They need all of those fresh foods that even our working families sometimes are like, oh, that's too expensive. I'm not going to purchase that. And so just understanding as a community and as a society, especially if they're getting government funding to eat and you're feeding the whole family, now you have this child with chronic kidney disease who can't eat canned foods, who can't eat certain things, who can't eat. They're very limited and have to have all the fresh things. How much is that funding or that money or that supplement going to stretch for that family to get the adequate nutrition that they need? And I think that's something that we absolutely don't talk about or don't empathize with when they're trying to make that money stretch. But you have this one child who specifically needs all these expensive foods. And so we do have a food program as well that we try and help give some food to some of those families who may need that help.
That's good. So it sounds like resources on top of resources to help this child do well.
Right.
From the nutrition standpoint, from your standpoint as the expert. So when it comes to counseling and resources, you all have so many resources. And you were saying that some of the parents and the children will sometimes need therapy just because everybody's just overwhelmed by the changes.
Right.
And so are most people kind of open to that from what you've seen?
I think the majority of people are open, especially our patients on dialysis, because if you think of a teenager, you're like rocking their world. They think they're about to graduate. High school is great. And then you have to be on dialysis or you need a transplant. And so we have counselors actively in the dialysis unit to be available for these patients and their parents. They can schedule appointments. And so we try and make it convenient that they can have their counseling sessions on the days that they have dialysis. And so that's super helpful. And I think a lot of people take advantage of that. Also, you're missing a lot of school if you're on dialysis 3 to 4 times a week. And so we have teachers who are actively in the dialysis unit who are also helping the patients with their work and making sure they're getting everything complete. They actually also reach out to the schools to find out if they're behind on anything, if there's anything that they can do to help in dialysis to get them ahead. So it's so many resources available to try and help ease that transition or their new lifestyle.
I did not know that they had teachers that can come in and help. That I can imagine as a teenager having to do work, outside of school and knowing that there's someone that you can ask questions or that can help guide you. That's like, you can't put a price on that for that.
Because you're sitting there 3 or 4 hours getting dialysis anyway, and you can at least, they can help you with your work or have any questions. So I think that's great.
Right.
And we encourage them to take advantage of that.
And then too, you think you're having your dialysis on that day, you can have your therapy on that day, you can get your extra help on that day. So I can imagine that really helps parents with them having to take off work or make whatever arrangements for the kids to be able to do that, trying to get everything kind of coordinated to happen on that day.
Exactly. It's helpful. And then to mention too, another stressor, because I always like to focus on these stressors, right, for the parents, because it's a lot, it's so hard. And it's easy for people to judge. But if you think about it, we're the only place that offers dialysis in the state of Alabama. So think about the families who live in Dothan or Mobile who have to bring their child 3 to 4 times a week. That's huge for their job, for their gas, the wear and tear on their vehicle. So some of the things that we need society to just also think about, not just the patient who's getting dialysis, but the sacrifice that their families are making to get them there to be able to receive their treatment. So it's a lot. It's multifactorial.
Right. And a lot of people probably don't consider that, because we think about adults who have dialysis, who can, and there are so many facilities,
right?
Not just all over the state of Alabama, just any state. There probably are so many, facilities, private facilities that are able to do that. But with kids, because there's such a special population and things, even though they're having dialysis, I'm sure that process is probably even looks different for them.
Right.
And to be able to get that care, even more reason why we need more pediatric nephrologists.
I agree.
To be able to do that. But I didn't necessarily think about how the parents or guardian or whoever has to make so many sacrifices to make this happen, to keep the child as healthy as they can be.
Right. And not having dialysis is not an option. So I know in the adult world, if you don't show up for dialysis, whatever, that's on you. In the pediatric world, if you don't show up, we're obligated to report it. So we will call the police and say, we don't have this patient here. So that's not an option in pediatrics. You have to call us and say, my car broke down, I don't have therapy, and we have to figure out a way to make it work for you to get there to get your therapy, at least by the next day. And so it's a whole big thing. It's not okay to just skip therapy in the pediatric population.
Good to know. Yeah. Thank you for letting us know that, because if some people may say, oh, you can just get it done the next day or the very next day, it's like, that can be a critical thing.
Yes. So that's an option. Even if our families, for some reason, if their water is turned off in their family, in their own peritoneal dialysis, or their lights are turned off. There have been cases we've had to admit those patients because it's a life-sustaining therapy. So we cannot have you at home not getting dialysis. So
with the peritoneal dialysis, you don't have to go too deep into it, but can you tell us how that differs from when they have to come in to see you or go to the pediatric facility to have the dialysis done?
Right. So our goal is for all of our pediatric patients to, if they have to have dialysis, to do peritoneal dialysis for multiple reasons. And the biggest one is that you're at home. You can do it at night. And so you can go to school 5 days a week. You go home. Your parents may connect you to dialysis at 10 o'clock at night. You may run for 8 hours. You disconnect. You go to school. You go about your business. And so that's what we hope, and that's our goal. But there are certain things that have to be in place, like proper housing, your anatomy in your body. And so if you don't have the correct anatomy to put the dialysis catheter in your peritoneum, so really like in your abdominal, in your close to your abdominal cavity, so in your peritoneal space, some patients just can't do it. They've had multiple GI surgeries and it's not an option. Some parents say, I don't feel comfortable. I'm scared. I don't want to be because you're at risk for infection. They don't want that responsibility and would rather bring them in. And so we're hopeful that the patient can do PD because it just makes it easier for their lifestyle, but there are different reasons. And a big one is like their anatomy or what other comorbidities they may have that doesn't allow it. Or if they've done it and they continue to have infections, and they're not able to do it. But that's our goal, is we prefer PD.
All right. Awesome. And so we know that patients can be on dialysis, but in some cases, they may end up needing a kidney transplant for various reasons. Can you talk a little bit about how that process may differ from adults? Because, a lot of times people will think about, getting on the transplant list for adults who need a kidney transplant. Tell us a little bit about how that looks for pediatrics.
Right. So the good thing about pediatrics, our pediatric patients get kidney transplants much quicker than the adult population. So they're not on the wait list as long. They do get priority. And it's like a point system. I won't go into detail. So your time on dialysis also counts and kind of pushes you up on that list. But our goal is to always do preemptive transplants. So what that means is before they start dialysis. And so if I see a patient that I've been following and I'm like, oh, we're getting towards that, or I know we're going to need a transplant in some case, I'm going to follow you much more closely. monthly. I'm going to get labs more frequently. And then we refer you to our transplant clinic. And so we have 3 specific doctors who follow transplant. And they go and they do an entire day of like eval. So they see the transplant surgeon, they see the transplant nephrologist, they see the social worker, they see the teachers, the finance people, everything, the psychologist, to make sure the family and the child can handle a transplant, because there are a lot of people in line to get this kidney. This is like golden.
Right.
So we want to make sure once you get it, you are going to take care of it. We're going to make sure you take your medicines every day. So I tell my parents, when you're with me, this is an audition. And so when you go to transplant and they present you to the transplant committee, they're going to ask me, do they miss their appointments? Do they take all their medications? Do they return your call when you call them back? Because when you get that transplant, if something happens, we need to be able to get a hold of you ASAP. Mm-hmm. We need to make sure you take your medicines every single day on time. And so our goal is to get a transplant before they start dialysis, because studies show they just do better if you do a preemptive transplant. But we have a lot of patients who just can't wait and on dialysis. But they can either do a deceased donor transplant, or they can have someone to, a family member or someone, a family friend, to donate.
Okay. All right. So you hear so many different things about how much water we should drink. So I know that may or may not look different for kids versus adults, but just generally speaking, and I know that, you know, depending on what a pediatric patient has going on, the amount of water that they drink can differ. But what's a typical, let's say someone who doesn't have any known kidney issues, how much water should a child drink per day?
Right. So here we go again, nephrologist doing all this math. That's the joke. And so it's based on body surface area, and people don't even know their kid's body surface area, right? And so we'll say like 1.5 liters per body surface area. So I just kind of give my teenagers up a range. I'm like, you should be drinking at least 2 liters to 2.5 liters of water a day, which isn't a lot when you think about it. So I tell my teenagers at least 2 liters. Like, give me 2 liters. Our younger kids, probably a liter, but it's like kind of based off their size. So like your body surface area. So maybe a liter or so. Again, our transplant kidney patients have to drink a lot of water, which can be hard. They require much more water, but our teenagers, I tell them at least 2 liters a day.
Just a general rule.
General rule.
Yeah, because, right.
At least 2 liters.
Right. Because, you know, as parents, they're not going to think about the calculations. No. They're going to like 1 bottle, 2 bottles, you know.
Yeah. So I show them like 2 liters. Like, finish this before you come home from school, and then finish the other one once you're home. And so kind of have those goals. But I tell them at least 2 liters a day.
Okay. All right. Well, this has been an incredible interview. You have enlightened us on so many different things when it comes to the kidneys, and I just appreciate your time. I appreciate your expertise on this area. And so if someone wants to schedule an appointment with you, what's the best way? And I know there are different factors, like they need to go through their primary care doctor, you know, right. But if someone is just, if they're looking for a pediatric nephrologist, how would they be able to get in touch with you?
Okay. Thank you for having me. It was great to just kind of enlighten people on things about the kidney and all the things it entails. But if you would like an appointment with me, I'm at Children's of Alabama, University of Alabama in Birmingham. Your primary care doctor would need to contact our clinic, because we are a subspecialty clinic, so we would need an official referral. But they can contact our clinic, and the phone number is 205-638-9781.
All right. And do you have social media? If so, how can they look for you on social media?
I do have social media. I'm on LinkedIn under my name, Tennille Webb Humphreys. I'm also on Instagram at tweb_hump. If you want to follow me. But LinkedIn, you'll probably find more information that you need.
All right. Well, thank you.
Thank you.
Thank you for tuning in to Voices for a Healthy Legacy. Until next time, I'm Dr. Andrea White.